Today I'm speaking with Dean Spears. Dean is an associate professor of economics at the University of Texas at Austin. He's also the founding director of RICE, a nonprofit research organization focused on early life health and well-being in India, and the director of the Population Wellbeing Initiative, a global priorities research center interested in children, parenting, and the future of population growth and social well-being, among other things.
Why neonatal mortality is so high in Uttar Pradesh.
Neonatal mortality comes from largely being low birth weight, and underweight babies largely come from underweight moms. And in this district where we work, about a third of the moms are underweight in the sense of having a body mass index below 18.5. And so why are moms underweight? Well, some of the reasons that moms in Uttar Pradesh are underweight are the reasons that sort of everybody in Uttar Pradesh has worse net nutrition than they might, such as the disease environment and poor sanitation. So moms and babies and dads all sort of live in a place where, sanitation and, yes, there's still open defecation here, mean that people are exposed to germs that use up their nutrition, that sap their nutrition and their energy, through diarrheal disease or just fighting infections. But it's not just the poor sanitation and disease environment that's causing so many moms to be underweight. Very importantly, it's also social forces like gender inequality and the moms being socially low-ranking people.
Can you say more about that?
Yeah. So mothers in India tend to have their babies at younger ages. Unlike in, for example, sub-Saharan Africa, where childbearing careers are more spread out in age, a lot of the babies in India are born to moms in their early 20s. And that's a time where women in India tend to be particularly likely to be underweight. You might just be thinking, it's a poor country, that's why there's undernutrition, but there's more undernutrition in India amongst women of childbearing age than in, for example, sub-Saharan Africa or the rest of the developing world. And what we see in India is this distinctive pattern where, especially in a place like Uttar Pradesh, the youngest women, in their early 20s are particularly likely to be underweight. And as they get older, gain more social status, have children, they become less likely to be underweight. So the likelihood that a woman's underweight falls in age in a way that we just don't see in the same way in the rest of the developing world. So India has this double challenge where mothers tend to have babies young, and that's when they tend to be underweight.
Right. And why is it that this is happening in India and not in countries in sub-Saharan Africa, for example?
I think a very big reason is social status and women's status and the sort of hierarchy that you find especially in traditional households. Not all households are like this, but let's zoom in on a special case that it's easy to learn from, which is joint households. And so Diane Coffey and Ritika Khera and I wrote a statistical paper about learning from joint households where you have two brothers, they grew up together into adults, they got married, and they all lived together. And so in a household like this, the wife of the older brother is socially higher ranking than the wife of the younger brother. And the wife of the younger brother, the lower ranking daughter-in-law, is expected to do more work for the family and is later in line for getting the food she needs to eat, even during pregnancy. And so that's a situation where we can see an effect of a difference in women's social status, even comparing, cousins, their kids who live in the same family, live in the same house, live in the same village. And so a lot of things would be held constant. So what do we see? Well, we do see that the lower-ranking daughters-in-law are thinner, and that's even though they have the same height. And so it's not about their early life nutrition. It's about what happens to them in adulthood.
Interesting.
Yeah, it's like we have a little experiment here. We can look in these families as petri dishes to see, holding these other things constant, what's the effect of mom being underweight for these social reasons?
Yeah.
So what is the effect? Well, we see that the children of the lower-ranking daughter-in-law are more likely to die neonatal deaths, and we see that they're more likely to be stunted and so small in other ways. And so in a situation where we're pretty sure that the difference in in maternal nutrition is coming from these social forces, we're seeing it all the way through into neonatal mortality.
Evidence of KMC's effectiveness.
So there was a 2021 study in the New England Journal of Medicine that was the IKMC program, or the immediate KMC program. And basically what they were studying was the benefits of doing kangaroo mother care even sooner than it might otherwise happen. And so it's not like, kangaroo mother care versus nothing. It's kangaroo mother care versus conventional care in a radiant warmer machine. So the control group in this study was still, in a hospital, still under medical supervision, and, was in a radiant warmer. And then the treatment in this IKMC study was, KMC, skin-to-skin contact on the mother's chest and all of that. And it's in, poor countries. They did it in 5 hospitals, 4 in Africa, and 1, what I would consider to be a relatively privileged public hospital in India, because it's in Delhi. It isn't this context. And, what they found is that there was less neonatal death amongst the babies who got, immediate KMC than amongst the babies who got conventional care, even with radiant warmers and machines and medical care.
That is wild.
That's wild, right? So this is so good that it's at least holding its own against, conventional care with a radiant warmer. In fact, they stopped the trial. They decided that, we couldn't ethically continue doing this experiment because the KMC was so good. And so, and even in developed countries where there are lots of resources, a lot of the conversation right now is about, let's, at least for a little bit, take the baby out of the incubator or the radiant warmer and, put it on mom's chest for a little while. Now, I'm not a medical professor. I'm an economics professor. I'm a social scientist. And, what I think is interesting and what, an economics professor can talk about is sort of why wasn't this thing happening before? And, how do we understand the social science of making it happen and getting families involved? But if you look at what the medical literature says, they wouldn't be surprised that this is helping because, that's what they find when they look at experiments for this. And, the frontier that they're asking about is this maybe even better than conventional care in some cases? So amongst the babies in this program, 11% of them die in neonatal deaths. It is possible to do better than that. And 11% is a lot better than what would have been likely to happen otherwise. So this doesn't mean that the project of neonatal healthcare is done forever, but it means that we have something wonderful available if it can be organized and brought to the babies who need it.
How cost-effective is KMC?
Let's talk about that cost-effectiveness number. The sort of highly cost-effective things that you might be familiar with include maybe giving out insecticide-treated bed nets, right, to save lives against malaria. And so one of those nets, I think, costs on the order of $5. But if you give out a lot of them, then sort of the low probability of saving a life for each one all works out that you can save a life for, something in the low thousands, right?
Yep.
This is a different way of getting to a cost-effectiveness number in that ballpark. It costs our program about $5,000 a week to run. And, that's sort of a cost of staffing and management and some supplies. And so when we did our cost-effectiveness computations, we, at that time, were able to have about 11 and a half babies a week passing through the program. So that works out to $430 per baby of average cost. So the average cost of the program, when we did the cost effectiveness calculation, is $430 per baby. Mm-hmm. Now, how you get from that number to a cost per life saved depends on, how many lives the program is saving. And so here's one sort of really basic way to think about it. A plausible bound for saving lives is that is 1 in 10. A 10 percentage point difference in neonatal mortality, like on the order of 1 in 10 lives are being saved. I actually think it's better than that, but that's going to make the math easier.
Okay.
Right? And a plausible bound for the cost is, in the hundreds of dollars per baby. So hundreds of dollars of cost per baby times, 1 in 10 lives saved gets you a cost in the low thousands, like in the thousands of dollars per life saved. And, that's basically the whole story of the cost effectiveness. But going forward, the program is helping more babies than 11 and a half per week. And so, that means a few things. One, it means that there's an opportunity to put more funding to good use. In order to really reach all of the babies who are, appearing, we're attracting babies from the smaller clinics are coming instead. We're catching more of them that pass through. We're persuading more families to stay instead of leaving. For all of these reasons, more babies are coming, and so that means we need more nurses. And now, the good news is, in economics, we have average costs and marginal costs. And the average cost is the average cost per baby. That's like that $430 number that I said before. The marginal cost is the extra cost of reaching another baby. And this is a program where there are lots of scale effects. Where, once we have a manager who is organizing the shifts of which nurse is on home visits and which nurse is on the overnight shift. And believe me, this is a big and thankless task. But once we have that nurse doing it, that is done. And so the marginal cost of helping another baby, we don't have to hire another person to do the scheduling. And so chances are the marginal cost of helping more babies is even lower than that $430 average cost. And so we're in a situation where, on the one hand, because the program is successful in attracting more demand and doing a better job of finding the babies that can be helped, we're able to help more babies than we thought would be the case. On the other hand, we're probably helping or treating the marginal baby for less expensively than the average baby. And so that means there's a real opportunity here to cost effectively save lives. So if a listener out there is eager to find a way to, make a cost-effective, life-saving donation in a place where there is an opportunity to absorb the funding and put it to good use, riceinstitute.org, and we think we have that right here.
That is really exciting.
Is KMC better than direct cash transfers?
So we interviewed Paul Niehaus last year about the organization he co-founded, Give Directly, and he made the case that in many cases, kind of global health and development is better served by people just directly giving people cash rather than trying to figure out how to deliver a specific program to them. Why do you think that is not the case here?
Well, first off, I think he's right that is probably often the case. So I don't disagree with him in any sort of big picture way. In this case, it goes back to the fact that healthcare involves a lot of market failures. The idea behind giving someone cash is that then they're going to be the customers who can go out and make sure they're getting a good product and getting the product that's actually valuable for them. Right? But there's no real way you could take the $430 that on average this program is spending per baby and buy something like this in the market. The private providers here aren't providing this quality of care or even a very high quality of care at all. Babies born in private facilities in Uttar Pradesh are actually more likely to die than babies born in public facilities in Uttar Pradesh, even though their families are better off. And then there's just the well-known market failures of, do the parents know that they need this, right? So yes, it probably is true that in a lot of cases, giving cash is a good idea, but it's not going to provide this outcome of neonatal survival. This is a case where there's a special opportunity of these moderately underweight babies, not the very most underweight babies, but these moderately underweight babies where, this sort of intervention of low-cost neonatal care can save their lives. But it's not going to happen if it doesn't happen in an organized way.